Hello, everyone. Welcome to our mental health OSCE station. I'm Fatima. I'm going to go through the mental state examination, and my colleague Sai is going to go through the suicide risk assessment station. So, just some key points about mental health history taking. First, you need to determine the symptoms which brought the patient in. So, for example, you can do a quick depression screen to check for the triad of low mood, anhedonia, and fatigue. Now, can someone tell me what I mean by anhedonia, or how can you ask about anhedonia? I'll just give you a few seconds to answer. You can either unmute yourself or drop your answer in the chat box. Exactly. So we've got an answer here. So it's basically when you lose interest in things that you were previously interested in. And for bipolar, you can check if they have fluctuations in mood between periods of low mood and episodes where they feel really happy with lots of energy. Next, you need to see if they've come in voluntarily or if they were detained and who prompted it. Was it the patient themselves that they've recognized that there's a problem and they've come in to ask for help, or family members or friends? And of course, never forget risk. So this is the risk from the patient to themselves or to others. So ask about history of self-harm, any suicidal ideations, or any plans to harm others. So we will explore these in more detail in the coming slides. Now, starting with the mental state examination. Why is it important? It basically helps you elicit signs and symptoms of mental illness, and it also helps you identify the risk factors that the patients might have. So with the mental state examination, you basically need to look out for a few components that we will go through. The first one of these components is the general appearance of the patient. Now, this is mostly based on your observation. So how do they look? Is there any evidence of self-harm? Do they seem like they're comfortable talking to you? Do they seem like they're uncomfortable? How is their physical health? You also look at grooming and hygiene. Do they look like they can take care of themselves? Are they dressed appropriately? This picture is a picture of Anne Hathaway, and she's playing the role of someone who's suffering from bipolar disorder. It's an episode in Modern Love. It's actually interesting to see. So the whole night she couldn't sleep. She was too excited. She had high levels of energy, and in the morning she dressed up this way to go for grocery shopping. So this is her dressing inappropriately for what she's going to do. Next is behavior. In this component, you basically look for nonverbal expressions of mood. So, for example, when you're talking to the patient, are they maintaining eye contact? Or how is their general attitude towards you, the person who's talking to them? Are they attentive? Are they guarded towards you? Are they showing interest in the conversation, or are they disinterested and disengaged? Are they hostile and aggressive? And you also look at their psychomotor activity. Is it increased or decreased? So, for example, can you spot any body tics or any inappropriate facial expressions? So, this is actually a good example of how much you can tell by a patient's behavior. So on your left, you can see the patient having her knees curled up to her chest, and her arms are around her knees as well. So just from the way she's sitting, you can say that she has a guarded behavior. And obviously, I know this is just a picture, but you can also say a lot by the way she's maintaining eye contact or not. Next is speech. So first of all, you need to see if speech is present or absent. When I say speech is absent, I'm referring to mutism. So some patients just refuse or can't talk. Now, if the speech is present, you need to see if it's spontaneous or not. What do I mean again by spontaneous speech? I mean, you can say if they answer spontaneously to your open-ended questions. Next, you can comment on the rate and quantity of their speech. Now, can someone tell me what I mean by pressure of speech, or how will it usually come off if the patient has pressure of speech? Feel free to unmute yourself or drop your answer into the chat box. Yeah, so I've got an answer here. Yes, it's basically when they're talking faster than usual and they feel like they can't stop. And usually people have trouble following the conversation because they're jumping from one topic to another. And this pressured speech can actually be seen in schizophrenia, very common. You can also comment on the tone and volume. So, are they talking loudly or quietly? Is their speech clear and articulate, or is it slurred? Obviously, you don't have to mention everything in speech. So, let's say that when you're talking to the patient, you only notice that there's an abnormality in the rate and quantity. So, you can only comment on that. The others are just suggestions, or if it was something too obvious. Now, the other component is mood and affect. Now, it's very important to distinguish these two. Mood is basically the sustained emotional state. So it's the patient's overall general mood, but it's how they think they feel. And you can basically just ask them directly. So some questions that might be useful are, how do you generally feel most of the time? Or what is your current mood like? Or have you been feeling anxious lately? Or have you been feeling low lately? And the words that you later on use to describe the patient's mood are happy, anxious, apathetic, irritable, or relaxed. So these are just some suggestions. Affect is the outward expression of the patient's current feeling state, meaning how you think they feel. So this is not by asking questions, this is just basically by your assessment. So some words that you can use to describe affect is, for example, if again they're sad or agitated. And when I'm talking about the range of affect, so let's say with the normal range of affect, it means that there's a normal variation in facial expression, or tone of voice, or use of hand gestures and body movements. While, for example, a restricted or constricted range of affect is when this is reduced, or they basically do not show any feelings or do not react to anything appropriately. Next, we have the component of thought. Now, you can assess thought under three domains, basically. The first domain is form and stream of thought. The second is content of thought. And the third is possession of thought. We will go through these in more detail, and I'll tell you how you can ask these questions in a history-taking station. But basically, for form and street of thought, it overlaps with the examination of speech. So if you remember, in speech, we had pressure of speech, right? So in thought, you can also have pressure of thoughts. Or for example, when we had poverty of speech, you can also have poverty of thoughts. So that's for form and stream of thoughts. When I say the way in which the thoughts are linked together, I mean basically the speed and flow of thoughts. Does the patient have something called flight of ideas? Now, can someone tell me what I mean by flight of ideas, or how will the patient appear if they had flight of ideas? Feel free to unmute yourself or drop your answer into the chat box. Exactly. So I'm getting some good answers here. They basically will come off as jittery, anxious, very excited, and they'll jump up from one topic to another when the topics are not really related. And it's usually very obvious. You can see it in bipolar disorder or schizophrenia. Now, for the content of thought, it's about what ideas and thoughts they have. So, do they have any suicidal ideation? Do they have any thoughts of self harm, any obsessions or jealousy? And then for possession of thought, it's the belief that others can manipulate their thoughts. And then we'll talk about that in the coming slides. So these are again some words on your left that you can use to describe the thought form. Now, I'll say a few questions that you can ask in your history taking to find out more about the thought form. So you can say something like, do your thoughts seem faster than normal? Or does your mind seem to be slowed down? Or do you ever feel that your mind is suddenly wiped out blank and you have no thoughts at all? Now, another question that you can ask is, do you ever have the experience when your thoughts suddenly stop? So these are just a few suggestions where you can ask the patient directly to find out more about their form and stream of thoughts. And then you can describe it to your examiner using the words on your left. Thought content, you can start by an open question saying, has anything strange or unusual been going on? Or do you ever feel that people are following you? Or do people spy on you? Or is there anything you can do that other people can't? Then you can also ask about self-harm and suicidal thoughts in the thought content, like we discussed before. For thought process, you want to find out if the patient is experiencing the phenomena of thought insertion or thought withdrawal or thought broadcasting. So for thought insertion, you can ask them, do you ever have thoughts in your mind which are not your own? So this is where the patient feels like someone is actually putting thoughts in their head. With thought withdrawal, you can ask, does anything or anyone take thoughts out of your mind so that they're not there anymore? For thought broadcasting, you want to see if the patient feels like everyone can hear their thoughts. So you can say something like, can people tell what you're thinking? Now, if they say yes to any of these questions, you need to explore it more. So for example, with thought insertion, if they say, yes, I feel like someone is putting thoughts into my head. So you can ask, so what are these thoughts usually? Or do they always happen? Or how often do they happen? Now, the next component of the mental state examination is the perception and cognition. So with perception, you want to find out if the patient is experiencing any hallucinations or pseudo hallucinations or illusions. So as human beings, we all have five senses, but usually when these senses happen normally, we get external stimuli to trigger these senses. But with hallucinations, the patients feel these senses being triggered, but there is no external stimulus that would trigger this. And the patient believes that they're real. So, for example, the patient can feel like they can hear voices that no one else can hear. Or some patients, I actually saw a patient in my psychiatry placements, and they felt like ants are crawling under their skin. And it was really distressing for them, but they thought that that is real. So, again, you need to ask if they say yes to any of those questions, you need to ask more detail. So, for example, with auditory hallucinations, you can say, are they directly talking to you or are they talking about you? How many voices can you hear? Are they male or female? Are these people that you know in your day-to-day life. And here, actually, you have a window of opportunity where you can check for risk. So you can say, do these voices tell you what to do? Or do they tell you to harm yourself? Do they tell you to, let's say, harm others? And you can also see if the patient lives with any children or if they have any children, because this would raise a safeguarding issue then. And sorry, guys, can you please mute, make sure that you put yourself on mute? I can't hear you if you're asking a question, sorry. But yeah, so either as part of perception or cognition, you can check if the patient is oriented to time, place, and person. So do you know where you are now? Do you know what day it is? Do you know what time it is? Do you know who you are? And just to make sure that you cover everything in the cognition component of the mental state examination, you can do a quick mini mental state exam, which would check everything, and it should cover everything in cognition. Now, the last component of the mental state examination is insight and judgment. You want to find out if the patient is accepting that there is a problem and that this problem is coming from a mental illness that they're experiencing. And you need to see if the patient is aware that they can ask for help and there are potential treatments for them. So how do you ask that? Again, you just ask that directly. You can say something like, do you think you have a problem at the moment? Or do you feel you need help with your problems? And the next thing, as part of the judgment, you can check for their clinical judgment and risk assessment. So you can give them a hypothetical scenario to see how they would react. So you can say something like, if the house was on fire, what would you do? And then it would be a red flag if the patient said something like nothing, or I would just sit there. The ideal answer would be that the patient would either ask for help, shout for help, or try to run away from that danger. So this brings us to the end of our mental state examination. I know it feels like it was a lot of information, but the best way to practice this would be in your psychiatry placements. So I used to have this sheet that's in front of you right now printed out, and I had either a foundation doctor or a trainee to observe me take a mental state exam. And then when I wanted to report back using SBAR, I would have this with me just to make sure that I check the important bits. And again, just like I said earlier, you don't need to go through every single bit that you see. You only have to comment on things that are really obvious or really prominent in the history. So do you guys have any questions about the mental state examination before we move on to the suicide risk assessment? So we can start by suicide risk assessment now. And if you guys still had questions about the mental state examination, I'll be here on to answer your questions on chat.
Thank you, Fatima. So my name is Sai Pilarizetti, and I'm going to be continuing this presentation and talking about suicide risk assessment. So if at any point anyone would like to ask any questions, if anything isn't clear, please feel free to unmute yourself or put a message in the chat box and I'll get back to you. So basically, just to start off with suicide risk assessment, this is something that could, as Fatima said, you should be doing this during a normal mental health history as well. Obviously not in this much detail if it's not required, but this could be a separate OSCE station, and it could in fact be an independent assessment that you would have to do on someone who's attempted suicide. So this is something that's very important. The way we're going to be breaking this up is into before, during, and after. I think this is the best way to do it. It gives structure to your history, and it helps you remember everything that you're supposed to say. So in terms of the mental health history, so you're going to want to get a bit of a history from them as to, if they have a past history of any psychiatric issues, any medical issues which could be relevant to their current attempt. You're going to want to look for mood disorder psychosis. So it's really good practice to, when you're taking a history, to kind of form a little differential in your head. And a good way to do this is, one way could just be to ask all the questions together. But I think what would be quite useful to yourself is to break it down. So say you want to try to get a differential between depression, psychosis, and anorexia. You should ask the depression questions together. So anhedonia, do you feel that you no longer enjoy activities, low mood, fatigue? If you ask those together, and then you move on to your psychosis questions, such as thought insertion, hallucinations. One, it shows your examiner that you have good structure. You're actually trying to figure out the underlying condition rather than just pelting out questions. And it also gives much better structure to your history. So if you wanted to ask about psychosis, try to see if you could eliminate that. You could ask about thought insertion. And you could ask, do you ever feel that, there's any voices that only you can hear, or do they have any visual hallucinations as well? Visions that only they can see. And it's the same thing with anorexia. You could ask them about their eating habits, about their appetite, about losing weight, because anorexia is, I think, is linked very strongly with attempts of suicide. So that's something that you should keep an eye out for. And we'll come back to the rest of these at the end. Right, so before. So it's always important to think about what's happened before and to get the patient's perspective. So you could ask them, was there any particular reason that caused them to take this action? Could be, fights between a family, friends. It could be being ostracized from other people that they're usually quite close to. So it's important to delve into these to try and figure out why they possibly could have taken this move. Next, you could ask about if the self-harm or suicide was planned or impulsive, because this really differentiates between those who genuinely wanted to harm themselves or kill themselves versus those who are doing this for attention-seeking purposes. So if it was, if it actually was planned, and if they took precautions so that they wouldn't be found, then that's a much higher, it's much more likely that they wanted to follow through with the plan. So it's important to determine that. And like I mentioned before, were there any precautions that they took, not to be found, such as, locking doors, writing a suicide note, things like that. Next, was alcohol or drugs involved? Because those are, I think, very, very important to cover when it comes to these. It may be a bit uncomfortable to ask about these things, but it's very important that you do. So was alcohol involved? Were recreational drugs involved? If alcohol was involved, how much, what kind? Same thing with recreational drugs. It may be a bit uncomfortable, but it's one of those things where you need to go through these. Next, so during. So it's important to try and sensitively ask, I think, could you please tell me a bit about what happened exactly, how you went about it, because I think it's very important that you're able to get a very good history from this, because it's the most important part. So you can ask about if they did, take an overdose of medication, what medication was it? How did they get access to it? And how much did they take? If it was cuts, you could ask about where did you cut yourself? How many times did you cut yourself? What were you expecting this to help with? How were you feeling when you saw the blood or when you were being cut? And how do you feel, afterwards? So those are important things to ask about. When and where. That's another thing. So were they, in their room with the door locked, or was it, in a public place? These are, again, like I said, you're able to differentiate between if they really wanted to go through with it, or if it was for attention-seeking purposes. And how were they discovered, and what did they do immediately afterwards? So these are the things that we would aim to be looking at and during. So afterwards, this is again, you can ask about, how they feel now, looking back on it. Would they do it again? How are they feeling now? Would they do it again? Is there anything that would stop them from doing this in the future? This would be a good time to ask about support networks, like if they have any family or friends they can talk to, and who they can rely on to prevent this from happening again. And again, if you were to feel like this again, what might you do differently? Because as we'll come to afterward, this is something that you need to determine. If you were to discharge this patient, if you were to let them go, if they were put in a similar situation, what would happen then? What would they do differently? So this is something else that I think is very important. And finally, the risk assessment. So based on everything that all the information you've collected, and before, during, and after, you can stratify them into low, medium, and high risk. So a low risk would be, no further plans. They're regretful of what they did, and they're willing to, get help, talk to people, and you think it's quite unlikely that they would attempt this again. Medium is where you still do have a lot of risk factors. For example, the reasons for which they wanted to commit suicide or self-harm still exist, and they haven't completely gone. So that's another thing to look out for. And high is when they're still quite distressed. They still talk about planning to attempt to end their life again, and when they don't really, when you don't think they're being rational in their discussion with you either. So these are three things which are very important when you present your history to either the examiner or to a senior doctor. They're going to be asking you what you think your risk assessment of them was. So that's, again, very important. And like I said, it's important to also, go through the history taking thoroughly. So this isn't just the previous psychiatric history, like did they have any previous psychiatric diagnoses like depression, anxiety, psychosis? It's also past medical history. So if they have a bleeding disorder, which could be quite relevant if they were trying to self-harm in terms of cuts, you need to ask about their drug history. So this is medication-wise and recreational. You can ask about family history, which is very important. Have any other family members, attempted or completed suicide in the past? Are there any, psychiatric conditions that run in the family or that present in close family members? And I think when you're ending a suicide risk assessment, it's always important to try to get an idea of the social elements involved as well. So that's, who they live with. Do they have a support network in terms of friends, family? What do they do on a daily basis? Are they just at home? Do they have a job to keep them busy? These are some things that you need to look out for. Like I said before, alcohol is another big risk factor, and recreational drugs as well. And so yeah, when you're closing the consultation, I think it's important to, if appropriate, talk to them about what you think and possibly give them suggestions to strengthen their support group or to seek help where required. You will be discussing this with your senior colleagues before giving them a final plan, but it's important to give them some kind of reassurance. And I think more than anything in a suicide risk assessment or any mental health history, I think something that gets overlooked a lot is showing empathy. And I think that's very important for, acknowledging what someone else is going through, because a lot of times I think you get quite desensitized to the whole clinical environment, but you need to understand that this is possibly the first time that they're in, a hospital, a psychiatric ward, or wherever they are. And it's important to, acknowledge, that they're feeling quite stressed, and show empathy, and just a sentence or two saying, I can understand this must be a